this is Roger Green, host of the SurfingMASH Tsunami podcast. This week, we're offering 4 conversations from episode 19, our interviews with Mike Patel, Louise Campbell, and Sven Franke about their impressions of the EASL Congress meeting. Plus, instead of a vault, a special excerpt we cut from Louise's interview so that we could get the overall episode down to an hour and 10 minutes. It's got its own content, its own topic, and it's pretty powerful in its own right. This conversation is the first of 2 with Louise Campbell. This one took place on Thursday afternoon after the first day of abstract sessions and poster exhibitions. Louise spent several hours during that day at training sessions and speaking opportunities. She was the trainer, actually. But she did have time to catch a few major sessions. She starts by sharing her own view of the patient advocacy session that Mike Patel and Shira Zelversagi co-chaired the day before. She got to a bit of Thursday's general sessions after her own event and arrived in time for a presentation of a retrospective study demonstrating that VCTE could predict outcomes for patients in a population that was largely comprised of Asia Pacific, but not Australia. She discusses a Novo Nordisk industry session that covered, as Louise put it, and I quote, using the liver to diagnose cardiovascular disease, end quote. She ended her day at the Healthy Liver, Healthy Lives presentation, where Zobair Yanasi presented what Louise described as very startling figures about the increase in costs of Mazdal in the U.S., with a significant share of that coming in lost productivity in IT and industry. Also at that same session, Jeff Lazarus discussed how India was approaching the disease in a population where the number of MASH patients might reach 300 million. The rest of our conversation involved some of the drug presentations and the benefits and challenges around data development and big data. As you've heard already, and will hear repeatedly over the next month, this was an extraordinary meeting. These conversations should give you a flavor of the broader discussions we will offer in the next several episodes, starting with drug development on June 20th. We're chatting with Louise Campbell, our co-host, good friend, around since episode 3, has presented 5 hours so far at this meeting and is now acting like what she is in real life, which is an amazingly interested liver advocate. How's Milano treating you?
Louise Campbell.
It's lovely. There's a really, really nice vibe. It's quite exciting. I think, obviously, there's a sadness with the loss of Stephen. He's all over the posters. He's all over the presentations. His name's everywhere. So he's a great miss and loss. And I think that hasn't gone unnoticed throughout the conference. But the actual general vibe in Milan is very positive. Lots of good sessions, lots of good interactions with people. And now I've finished my commitments to the program, I can actually get to enjoy it myself.
Have you gotten to enjoy any of it so far?
I went to the patient advocate sessions yesterday morning, so the first morning, bright and early, which Michael Patel and Shira were presenting, which was actually a really, really good kickoff to the conference from my perspective, and a lot of people in the room, and it started it so positively. The room was packed. There were sessions from Jose Villaments from the Dutch patient liver program in what patients want for their questions from the doctors. There was then a doctor from Oxford who then presented the opposite side of what a doctor thinks they should be asking in their clinic and what they know the patient is coming in about the car parking and bits and pieces. And together those two were very, very entertaining. And I certainly hope that we can probably do something with the two of them and ourselves and get them to redo that, because it was very entertaining, and how their slides were prepared differently but covered a lot of the same perspective. So there was a bit of humour in the room with that. There was some discussion on stigma that just took off naturally about stigma that sort of generated a lot of discussion. Donna Cry got up. I said a few things because what was missing in the session from my perspective was there was no middle ground on the nurses spend more time with patients, for example, to answer a lot of the questions about health, how it's going to affect me, ask the questions that they want to ask. So it was a really positive kickoff to the entire conference, and everybody was buzzing coming out of that session. And I think they did a great job.
Well, that's fantastic. Mike talked a little bit about that on our phone call with him. He felt the same.
And there was a take home from it. They were saying that every person in health should ask their patients at least once a year, how does your liver disease affect you? Even if it's only asked once a year, then to take home that message that we must be asking this question, whether you're nurses, whether you're doctors, whether you're allied health dietitians, how does it affect you? That was a really powerful statement, and I think it's something we can all do. Remember to do that.
So that acts in the presumption that everybody knows how it affects them, or maybe they don't know and haven't thought about the question and you're triggering it for the first time.
But I think it shows that insight that you're wanting to know as a physician, as a nurse, and you're trying to find out. The assumption sometimes can be that how are you feeling? And a lot of people will say fine. My father's a perfect example of fine. And I go, all right, before the doctors, almost out the door, rate fine between 0 and 10. Oh, 5. Then the doctor turns around. So sometimes you have to prompt that question and you have to ask it in the right way. And I think that's what, for me, Jose was saying, put liver in the title. How does your liver health affect you? Not just how are you? To be specific, really get that into that nitty gritty and open up the dialogue.
So that sounds exceptionally interesting. I'm curious. So did you get to the general session today at all?
I got to the end of the general session. I was there for the sort of look at VCTE and its predictive value. So I was there for that discussion and how it can predict the outcomes. The majority of patients there were Asia Pacific, and they are doing a sub-analysis of Asia Pacific versus the Western populations because they're markedly different. Interesting enough for me, Asia Pacific was very strong, but there was no Australian part of Asia Pacific in the study groups that were utilised. But that seemed to be a fairly robust study looking at sort of 2 scans, the out measurements and how that altered. But I'm still digesting and all of the finer detail because you know how much you take in and you just go, let me get that right before I say that was thing. But it was a very positive outcome about how predictive you can be with these machines.
Well, good. Save that for the wrap-up episode.
I went over to the Novo Nordisk Symposia, which was an absolutely excellent and fascinating session. It was hosted by Quentin Henkhuzi and a lady physician whose name escapes me at the moment from Denmark. And they were excellent, but they were looking at managing cardiometabolic, using the livers to manage the cardiometabolic side rather than focusing on liver disease.
Okay, so did you give them a standing ovation at the end, since I know you believe strongly in the importance of doing that?
I did see Quentin a little bit later and said I thought it was a fantastic effort and exactly where we need to be sitting, that with certainly in primary healthcare, because that's where everybody foresees this being managed in the future. I'm not too sure how many primary care physicians are aware of that, given the volume and the numbers we are talking about, but that was where the prediction was in 5 years' time. I think they said that this would all be, the majority of cases would be all in primary care. So therefore, Ken and the team were looking at this whole thing, managing from a diabetic and endocrinology perspective and managing liver disease. But therefore, you weren't managing the liver disease so much if you were looking at reducing the cardiometabolic, improving the health and assessing all of those areas early in steatotic liver disease. So whilst it was a Novo Nordisk Symposia, it wasn't a Novo Nordisk focused event. And I think that was, again, the positive of some of the symposia. It's not biased towards semaglutide nor any of the products. None of the, I think there was a couple of slides on SEMA and their outcomes, but a lot of it was how do we manage this? How do we liaise? We're looking at cardiovascular outcomes. We need to prevent very much further upstream. And I do, if I could have got my pom-poms out, shaking them around the room and things like that, and I would have done, because I think that is where we are heading.
Yeah, although to do that, you would have been able to do high kicks, and with your knee, I suspect high kicks are still out of the question, yeah?
Well, it's kicking up 16,000 steps a day, but it's doing its exercises as well. But yes.
Well, bravo, that's fantastic. Good for you.
And then the last session I did today was the Healthy Livers, Healthy Lives presentation, where Zabir presented some very startling figures about where we're heading cost-wise in the US, not only in healthcare, but in the loss of productivity in it and to industry. And I'm a great advocate that a lot of this has to be done in tandem with employers as to their workforce and things like that. But Jeff Lazarus was there, WHO were there. They were looking at the Indian targets and how India has addressed fatty liver disease with 300 million again on their population expected to be problematic. So again, that was based on the work that they'd done a few years ago.
So it strikes me just from that we've known that India was out ahead of everybody else for a while in terms of policy, but also maybe derivatively because they had a drug faster than anybody else did, or a drug that they believed would work faster than anybody else did. And first thought. And second thought is you taught me about presenteeism back in 2021. Or 2020. It's something people had to be looking at. So it's good to hear that that's starting to get to focus, and delightful that WHO was there.
Yeah, I think Zabir put it, and of course he flashed through slides and lots of data, but I think if you, what they were doing was breaking down the productivity by fibrosis scale. For example, the productivity, I've just pulled up the figures here, was $18,000 per patient in 2021. And these are just startling figures. When you go up to 24 40, we're talking in the region of $258,000 in productivity loss per patient.
Per patient at what level? You said it changed by fibrosis level, so I'm assuming that the 258 was a higher level and the 18 was a lower level.
A NASH F0 was $4,109 productivity cost per person. At stage 0, F1, again, was the same. It didn't actually change until you actually hit NASH fibrosis 3 to $4,237. So it's very static, but it's still $4,000 productivity loss per person. Now, for small businesses, that's massive. But again, it's more of a global look and what the prediction is. These are mass figures, so therefore it's difficult. But yeah, we were looking at India as a target, and the way that they had shifted it, if I remember correctly, because people look at just liver disease, as we've discussed, and liver mortality rather than all-cause mortality, and therefore it's low on the agenda. And my intake out the session was that was what the WHO were sort of demonstrating, that it doesn't hit high on the agenda. It's kept in that liver area. But India used the target that 39%, I think he said, and apologies if I'm wrong, of patients with diabetes would develop liver cancer in India. And that was when the Indian government made a change. We cannot allow 30% of people with a condition to die of liver cancer. So I had to leave, but there was a stimulated discussion about maybe using a different mechanism to trigger the right outcomes that we want. And obviously cancer is a very important area for that. But again, plenty of studies showing all-cause mortality in low fibrosis scores is still higher than liver-related mortality higher up. So there's some interesting stuff to come. There's some very interesting abstracts I've scanned through that I'm hoping to get back to spend more time on and replay some of those.
So I'm listening to you, and part of my reaction is, I think I said this last week on the preview episode, and if I didn't, I was thinking it, and I'll say it now. Liver has really become like the 6 blind people on the elephant. You just described 2 days focused entirely on patient-centric issues and patient impact, except for the one VCTE study. At the same time that there are major presentations on all kinds of things. I think the drug stuff I think denifenstat was the only drug today. There'll be drugs in the general session tomorrow. There'll be a bunch of stuff in the late breaker, including, it seemed to me that Lilly jumped the gun. Lilly released results yesterday on the study that I believe is being presented here that shows that they have a significant impact on fibrosis, tirzepatide. They said 51% one level reduction versus 25 with placebo.
And I believe Matthew made a press release this afternoon about the data that's been used at EASL, but I haven't had time to read it.
I've not yet either. I'm trying to catch up with the stuff as best I can, but it's a little bit challenging from here. I miss you guys. I miss being there. You
would love it, and we miss you being here because everybody asks when I walk past them.
Happily, what I'm home for is going as well as it could possibly go. So at least that's the good news. My time is well spent. We joked last week on the preview about the need to clone Hannes, because there's actually one moment in this meeting where Karolinska is doing 2 presentations of his stuff at once, and he obviously can't do both of them.
Yes.
So this was a week I would have loved to have been cloned.
Well, I'm hoping the vibe from here goes into AASLD later in the year, because I think I do get a sense of motion. I was talking to Alina Allen as we left the Healthy Liver, Healthy Life session, and she felt the same way, that there's a general movement forward, there's a lot of enthusiasm in the room, and it's that progression. We might be saying the same thing next year, but I certainly hope that the work that we're seeing here is interesting, as some of these abstracts are very positive.
Look, I think in general, the approval of Rezdiffra, the movement of drugs later, and the compelling epidemiologic and health economic data is forcing everybody to look harder. We have to. When we called this podcast Tsunami 5 years ago, we did it for a completely different reason. Pache Stephen, but it's just the global consequences are massive.
What's interesting is the amount of conversations we're having about AI and looking at how to detect the populations quicker, but we don't have capacity in most areas to actually, once we've found them, what we're going to do with them. We can find them quicker. How do you manage them? I had the pleasure to speak to Simone Strasser, a consultant that I'd worked with in Australia, in the Royal Prince Alfred in Sydney, because she's over here with some of the Australians. And when we were discussing the Australians can be quite touchy about their medical records and whether or not some of the patients would turn around and say, well, if you did a screening, AI screen of their bloods and things like that, how did you get my records? Who gave you permission? So this whole thing of confidentiality, and I did see it when I was in Australia, that there may be issues that we don't see in, say, the UK or the US that we would need to adapt for in countries like Australia. I'm sure they take care of all of those as you go into different environments. And in fact, I know they do, because you're going to do all of that. But it's an interesting take, but there's a lot more of that. Now we've got something. Let's start to find those populations. And how do we do it? So I'm definitely getting that feel.
So just to recap for those who didn't hear last week's episode, I think the biggest theme of the preview episode was the shift in focus from excitement about developing individual drugs in small studies to what we could learn from larger data consortia. What brings that to mind in this moment is Hannes, one of the two Karolinska papers that are on at the same time, takes a look at the ability of FIB4 to predict and the high level of false negatives and false positives, and that you can actually do better than that with an algorithm constructed basically, if I remember correctly, ALT, AST, GGT, gender, age. Those 5 things are a better screening predictor than FIB4 is, So then you get to the issue that goes, where in the world are they doing ALTs as a standard metric? Or at least where are they doing them on standard on all diabetic patients, right? Since the correlations are so high. That would be issue number 1. And then issue number 2 would be, and after that, what are you going to do? Primary care is underinformed. Hepatology is under-resourced. It's going to create interesting challenges. But the good news, though, is the quality of discussion is so much higher.
Yes, people are having those discussions now. It is probably easier to case find quicker than it is to change and stop the Titanic in healthcare to get them to make a decision. And that takes years of business cases to increase capacity of staff, types of staff. So we do need to, whilst we're looking at trying to solve the solutions of poor liver health, stopping disease, going way further upstream to treat earlier, to save costs, to improve care, we also need to be in tandem having those discussions with governments about this is what we're doing to help this pocket, but we're in this side, we're going to need to improve what we deliver on this side into hepatology care or gastro care or endocrinology, who's going to be taking care of these patients. And that's not what happens at these types of meetings. And it's not something that I've formally been involved in before, where that comes from these meetings and goes to there. And whether or not that's the type of thing that Wilton Park get involved in, or that Jeff and the guys do, and Donna.
Oh, I'm sure that Wilton Park will get involved, and it's one of the reasons he's trying to get WHO to pay more attention, I think, with some success. That said, though, John Lennon famously said, life is what happens while you're busy making other plans. And the incretin agonists, right? I mean, the belief had been, at least among most of the KOLs that I know and trust, that a GLP-GIP wasn't going to be nearly as good as a GLP-glucagon. And that might still be true. Survodutide looks like a better drug for this than tirzepatide. But tirzepatide looks really good. And in a world where most patients will have been on some form of incretin agonist before they ever get to a hepatologist, right? Because if they're obese, 1 out of every 8 Americans has seen a GLP at some point. And the more we understand that as a class of agents, that's capable of dealing with virtually everything that we care about in metabolic disease, those will get stepped earlier. I have a friend whose 33-year-old son who was a offensive lineman, Division I in college football, and those kids 10 years later, either they're massive and have massive health problems or they lost 100 pounds. He's in category A. His primary care physician put him on Ozempic. His mother thought that was a scandal. I thought that was absolutely necessary. I explained to her why. She's a good friend. But if primary care started to look at people who are diabetic or pre-diabetic and obese and saying, I'm not even going to worry about getting you to an endocrinologist. Let's get you on a GLP or eventually maybe a double G now. Then what's going to happen is we will see fewer people coming to hepatology in need now than would otherwise. So it's not quite like we're putting our foot on the hose and therefore the flow is going to stop, but we're slowing the flow so that you might be able to reduce the rate of growth in incoming at the same time that you're picking up the ability to handle incoming. And we don't get quite so I'm more optimistic about this than I was a year and a half ago. A year and a half ago, I just thought we were going to get swamped. But as I say, this tirzepatide phase 2b data is intriguing. Some of the work we've been doing outside of this podcast, I've been learning that some hepatologists still won't touch GLPs, but many will. And in that regard, Ken Kuzi's wish is coming to fruition in many instances. So my optimism is that we may be able to, by treating the broader sense of metabolic disease, instead of seeing the liver as the thing to treat, the liver becomes part of the complex. And if you treat the complex earlier, the liver doesn't get in so much trouble. I think that's a more realistic path forward, frankly.
Yep. And I think that was the whole session that Quentin and the female consultant was Lisa Lotte Glod from Copenhagen. She did a great one of tying in the comorbidities to the liver and where it was tied in with that. So you're right, absolutely.
That makes me feel a little more hopeful as I sit 6,000 miles away. But all right, anything? Anything else?
Much more of it than I have.
Not in the middle of the night. I keep, like I say, it's been a little demanding. We'll see what I can do tonight. I'm confident that I will get to see the late breaker, because it's at 8 o'clock in the morning here.
I'm flying at that time. They concentrated it. It just means that it's more difficult to attend when flight schedules over the weekend.
So you see everything else. I'll see the late breaker and we'll compare notes, okay?
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingmash.com. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.